Well, good morning, everybody. Dr. Boudreau, thank you very much. Bob and Marianne, pleasure to be here. Appreciate your invitation. And it's wonderful to speak to such a big audience of people who really know this disease. So it's a pleasure. Thanks to Eric, I decided I'd leave my jacket behind on the table over there. But I am better dressed, right? Okay, got to find out how to make this move forward. Great. Okay. So for the next hour and a half, I'll talk a little bit about the role of the gastroenterologist because he's really the center of all of this. As everybody knows, neuroendocrine tumors are actually a lot more common and more prevalent than people have been led to believe over the years. And in actual fact, it is the second most prevalent cancer of the gastrointestinal tract. If you put all the GI components together, the incidence is very low. The new cases are very low. But because this is a slow-growing progressive disease, there are over 100,000 people in the United States living with neuroendocrine tumors that are metastatic. In addition, the principles of management of neuroendocrine tumors are very different from standard cancers. This is not like a typical lung cancer or pancreatic cancer. And so the management differs because the natural history of the disease is very different. As everybody knows, and I've stated, this is of increasing importance, and therefore it's wonderful to see an organization like yourselves coming together to promote advocacy. And as Eric pointed out, I think it's absolutely true. It has to be driven from the grassroots. This is a slide that comes from the North American Neuroendocrine Tumor Society deck. I think it's Rod Pommier who made this point so well. On the left, you see a classic neuroendocrine tumor, classic cancer. On the right, you see the neuroendocrine tumor. For a classic solid tumor, the base of the pyramid, it gets bigger and bigger and bigger until it metastasizes to lymph nodes and then spreads outside. Many of you will know that neuroendocrine tumors are upside-down sort of tumors, so the management has to be very different. You can have a very small, little, tiny primary tumor sitting in the small bowel somewhere with big conglomerates of lymph nodes and much of the liver replaced, so that the liver-dominant disease is what's going to impact on the outcome so that we can start addressing maintenance, control of the disease. As Eric pointed out, cure is not always necessarily what's possible or what your aims would want to be. So these diseases are different from what most physicians and oncologists deal with, and you really do need a specialist multidisciplinary approach, as has been suggested. Now, in thinking about this, there really are multiple ways that patients get diagnosed and identified. And I am always one to say that there are no two neuroendocrine tumor patients who are the same. Everybody has their own little differences in where the disease goes, how it spreads, how it's affecting you. So everybody does need their own special personalized approach to treatment. There are many things in common, of course, that allow us to talk to you about a group of symptoms or a group of presentations. But I think of it as actually being three ways that patients present. First of all, you can have a hormonal syndrome, which sounds great and easy if you know what the hormonal syndrome is. So, for example, I'm sure there are many patients in the room here who got labeled as having irritable bowel syndrome for many, many years. And lo and behold, of every 100,000 irritable bowel syndrome patients, there are going to be 5 or 6 that are going to have a neuroendocrine tumor. It's really a needle in a haystack. But if you don't think of the syndrome, you don't pick it up. And we'll talk about that. Second of all, you can actually get symptoms from the tumor itself. Many of these patients, as you know, will have a small primary, big lymph nodes, and widely metastatic disease, and ultimately it's the tumor itself, the growth of the bulk of the tumor that gives you symptoms, and that's very different from somebody who's got diarrhea and flushing, for example. And thirdly, which happens to many patients and is quite devastating, is you're feeling 100% perfect, life's going swimmingly, and you happen to fall down the steps and end up going to the ER where they get an X-ray and say, oh my God, look at this, you've got widespread disease even though you feel perfectly well. So those are the three big ways that I think patients generally will present. And obviously how and when you enter into this process is going to affect how we're going to manage you at that stage. It is important to realize that the only valuable thing to point out early on is if you catch it early enough that you can get a surgical cure, that's going to put you in a totally different situation. Unfortunately, many patients don't have that luxury. So surgery is the only curative treatment modality for this disease, And if you're lucky enough to be caught at a stage that it can be achieved, that's great. Many patients present at a later stage. And then the aim is to control the disease. So there are obstacles in the early diagnosis of neuroendocrine tumors. As I've already pointed out, rare diseases, people don't think about it. They're zebras, as we all know. It's like looking for that needle in a haystack. There are many other far more common diseases that will have very similar presentations. So everybody who has an ulcer, I'd say about 1 in 1,000 ulcers turn out to be Zollinger-Ellison syndrome. Very, very few patients with diarrhea and flushing turn out to actually have neuroendocrine tumors. Many of them have irritable bowel syndrome. And that everybody's presentation is different, and that you're often asymptomatic and living with minor aches and pains and small symptoms for many, many years, and that people don't focus on it. And that's, again, why it's important to have an organization and a meeting like this, because you want to foster awareness. So you need to be lucky enough to find that astute physician who has a high index of suspicion and probably tests many, many patients and gets negatives before they find the one patient that they could potentially help. So the delay in diagnosis is very common in these diseases. And this is another Neuroendocrine Tumor Society slide, because this number blows me away. 90% of NET patients are misdiagnosed initially. And that the average time to diagnosis is as much as 5 to 7 years. For example, irritable bowel syndrome or inflammatory bowel disease are the two most common GI diseases that are mislabeled and turn out to be underlying neuroendocrine tumors. Often the diagnosis is not made until the disease is metastatic, and then you have to control disease as opposed to cure it. So I'm going to talk about a couple of presentations that I'm sure many of you are going to identify with, and then we'll discuss the role of the gastroenterologist specifically. So here's a 47-year-old postmenopausal female, long-standing irritable bowel syndrome, diarrhea predominant. That's probably 10% of America. Presents to the emergency room with worsening cramping, abdominal pain, nausea, vomiting. She hasn't had a bowel action for a long time. Her exam is rather unrevealing. She's flushed. She has a hypertension. She's tachycardic, has a high heart rate, and the abdomen is distended and blown up like a balloon. So now what's happened with this person who has irritable bowel syndrome with diarrhea, she's developing an obstruction and abdominal pain. So something's changed. They do an abdominal x-ray, and they see that there's no air in the rectum, there's dilated air fluid levels in the bowel, and this tells us the patient has an obstruction. So this is not IBS. You put down a nasogastric tube to decompress this obstruction, and the patient feels a lot better. What do you do now? Well, she tells you she's had irritable bowel syndrome for many years. She's had 6 watery, non-bloody bowel actions. She initially responded to Imodium, but recently it hasn't been helping. The diarrhea wakes her from sleep. Diarrhea at night is not IBS. She's been incontinent. Severe diarrhea with incontinence is not IBS. Abdominal pain has also been more severe, no longer responding to her standard therapies. And as it so happens, she says, also I'm on hormonal replacement. How many women are told you're getting early menopause with your irritable bowel syndrome when in actual fact you have carcinoid syndrome? So why isn't this IBS-D? What are the diagnostic clues? And what's the right diagnosis? Well, I've gone through a lot of those. I'll show you some of those data. So in this case, for example, the most common symptoms of carcinoid syndrome: flushing, diarrhea, heart valve lesions in later disease, cramping, abdominal pain. This patient actually had all the features of the carcinoid syndrome. And remember, the differential diagnosis here is very, very difficult because it's a rare disease with common symptoms. So functional bowel disease or irritable bowel syndrome is the far more common disease that people are going to jump on and say that's the diagnosis. And that in itself is a diagnosis of exclusion. Inflammatory bowel disease, as a gastroenterologist, we see a lot of IBD, Crohn's disease and ulcerative colitis can look very similar. Celiac disease, 1 in 100 Americans have celiac disease, which is a gluten insensitivity. And that's a common disease. Lactose intolerance can give you diarrhea and cramping and abdominal pain. So before you get to even think of the secretory diarrheas, there are lots of other diseases that get in the way. And then as far as the neuroendocrine tumors are concerned, many present with diarrhea. It's not just the carcinoid syndrome, Zollinger-Ellison syndrome, lipoma, medullary carcinoma, and thyroid. So remember here, that diarrhea plus flushing makes you think of the carcinoid syndrome. And if you don't test for it, you're not going to find it. I've always been told that the menopause, the flashing of menopause is with sweating, and the flushing of carcinoid syndrome is dry. There's another disease called mastocytosis, where there are mast cells that secrete histamine that gives you very similar symptoms, and other rarer conditions like C1 esterase deficiency. So it's important to realize it's not an easy diagnosis to make, but if you don't think of it and you don't look for it, you're never going to find it. Okay, I'm now going to move over to another case. Let's talk about a 46-year-old gentleman who presented with heartburn, abdominal pain, diarrhea that has developed in the last 6 months. He's been on maintenance, omeprazole, a proton pump inhibitor, for the last 4 years, ever since he presented with a bleeding duodenal ulcer. He had H. pylori infection, that's the bacteria that causes ulcer disease, that was excluded. He avoids aspirin and non-steroidal drugs that cause ulcer disease because they caused his previous ulcer. So he has a history of an ulcer. We think it was NSAID related. 4 years later, he pitches up again with symptoms of acid hypersecretion. In addition, the diagnostician takes a history looking for MEN1 because ZE is often associated with MEN1, but there's no history or no family history in this situation. And his exam as a gastroenterologist, I can tell you, more often than not, we don't find much on physical exam. So he gets an upper endoscopy, an EGD, and he sees that one finds a large duodenal ulcer in the bulb. The gastric folds are thickened. His pH in the stomach is low, which means he makes a lot of acid. He doesn't have H. pylori, but his gastrin level is high. And he has what's called inappropriate hypergastrinemia, a high gastrin produced by the tumor, driving acid secretion, giving you ulcer disease. So why isn't this idiopathic peptic ulcer disease? As I said, 1 in 1,000 ulcers are not going to be idiopathic. We know that this is a non-NSAID ulcer, which is the majority of ulcers. He doesn't have H. pylori infection. So if you think about it, you've taken out most of the causes of ulcer disease. You've got to think of Zollinger-Ellison syndrome. So those are the clues in this situation. Gastrinoma or Zollinger-Ellison syndrome is a tumor that develops in the pancreas as a consequence of producing gastrin. That gastrin drives acid output, so you have excessive amounts of acid produced, ulcer disease, and diarrhea because you malabsorb. And the ulcer disease is quite serious, quite severe. It's almost always found, as Dr. Boudreau will know so well, in this triangle of Stabile, so that if you have the diagnosis by proving inappropriate hypergastrinemia, they should go for surgery in an attempt to cure these patients because they are often very small tumors very early on, even if the imaging is negative. There's another example of experience and multidisciplinary care coming together. As I've also mentioned, the two main types are sporadic disease, that about a third of patients with Zollinger-Ellison syndrome have multiple endocrine neoplasia type 1. So we need to think of all the genetic components and, again, expand the care to various other specialties. So patients with ZE present with complications more commonly than idiopathic ulcers. They often have heartburn and reflux because they make so much acid. A clue for the astute physician is they tend not to have gastric ulcers, they have duodenal ulcers. And that diarrhea may occur in isolation in these patients, which is often a clue. If you have a severe secretory diarrhea, even at high gastrin, think ZE, even if there's no history of ulcers. So the pathophysiology of this disease is such that the tumor, which is on the right-hand side there, the gastrinoma cell, it makes the hormone, gastrin. Gastrin gets into the bloodstream, drives acid secretion. The Pac-Man cell in the middle over there is the parietal cell that makes the acid. That would normally lower the pH in the stomach and switch off your acid secretion. So you all had breakfast this morning, you all stretched up your stomach, you all had a little bit of gastrin. Your gastrin drove your acid secretion. And if you didn't have a way to switch that off, we'd all have ulcer disease. But we have a feedback loop with a cell called the D cell in the bottom left-hand side over there that makes a medicine or paracrine substance called somatostatin, which everybody knows here. It's a natively occurring paracrine substance that the stomach secretes to switch itself off. That's why octreotide is so effective for neuroendocrine tumors, because it switches off locally wherever these tumors are. Unfortunately, the tumor is away from the secretion of the somatostatin, which acts locally. So although your own stomach has a lot of somatostatin, when you're making acid, you can't switch off the tumor. It's an inappropriate situation. So as a gastroenterologist, and as soon as I hear the word gastrin and hypergastrinemia, the first question out of my mouth is it appropriate or inappropriate? Because if you don't make any acid, or you're on medicines that reduce your acid, your body will try and restore that acid, and you'll have high gastrin trying to make acid. That's an appropriate response. The inappropriate response is when the tumor makes the gastrin, gives you the acid, and doesn't switch itself off. And there's differences, as you can see on this slide, that make up that disease. So the astute physician thinks of ZE, even though it's less than 1 in 1,000 ulcers. If you have severe ulcers, if you have ulcers with hypersecretion, if you're going to ever operate on anybody, so you do the right operation, if there's a suggestion of the hereditary components associated with MEN1, but most importantly, the clue is if it's a non-NSAID, non-H. pylori, an unusual ulcer, think ZE. Now, there are many different functional syndromes, as everybody knows. We've spoken about the carcinoid and the ZE syndrome. The insulinoma syndrome is a syndrome with excessive insulin, so people get confused because the brain needs glucose, so you get what's called neuroglycopenia. You have the insulin shock response or sympathetic overdrive, and surprisingly, you'd think that insulinoma patients would be thin, but many of them learn to eat to overcome those symptoms, so they gain weight. The glucagonoma syndrome is classically seen with a rash, so they often present to dermatologists, again, to expand on the multidisciplinary situations here. The Vipoma syndrome, or vasoactive intestinal polypeptide, gives you severe, overwhelming diarrhea. They come to gastroenterologists. And then there are others. There may be some people in the room with Cushing's syndrome, or acromegaly, or somatostatinomas, and other rare causes of functional neuroendocrine. So those are the ones you've got to think of and you've got to find. Now, Eric has already alluded to a lot of the management issues here, but there are some principles that I think hold true for everybody. Number one, confirm the diagnosis. That's really, 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 really important. I've seen many patients who were labeled, for example, as having Zollinger-Ellison syndrome that have hypergastrinemia, but they don't have Zollinger-Ellison syndrome. They don't make any acid. They have atrophic gastritis or pernicious anemia, and they've gone to surgeons for the wrong operations. So make sure you're dealing with the right thing. Take the slides out, get them looked at, have the KR67 checked, have a multidisciplinary meeting to make sure that what you're really talking about is the right thing. Then you can plan the treatment. Number two, control the hormonal syndrome. That's what makes people with functional tumors sick early on. Make sure that you've got that under control so you can then get on to the next step, which is staging the disease, determining its extent, and deciding how you're going to manage it. The first step, in my opinion, is to see if there's a potential for cure and resection. And if not, to still consider surgery. And I'm very in favor of debulking, and many of us are. I think the field is moving to being as aggressive in terms of controlling disease growth. Control the tumor. You might not cure it, but if you can keep everybody stable for many, many, many years, I like to tell people we'll grow old together. I'm growing old very fast. Management is multidisciplinary. You've just heard a long talk about it, and I agree entirely with the comments that Eric made. And it's diffuse. You need medicine specialties, surgical specialties, radiological specialties, etc. Somatostatin analogues, as you all know, are important for most of the tumor types to control syndrome. For ZE specifically, anti-secretory therapy is very helpful. Insulinomas may not respond very well to somatostatin analogues, although sometimes they do, but we do often need other therapies. And everolimus, for some reason, seems to be very effective in controlling insulin production in these tumors. You all know about the analogues. I think there was a lot of this discussed yesterday, so I don't want to bore everybody. But there are now in the United States 2 somatostatin analogues available, octreotide and lanreotide. They bind predominantly to the somatostatin receptor type 2, which is important for hormone production, and has now been shown in 2 very important studies that you all know about very well, the PROMED trial and the CLARINET trial, to control tumor growth. They're the drugs of choice for syndromic management and approved for specific syndromes, but in addition, also for others off-label. Okay, now I want to move to talk a little bit about the role of the gastroenterologist specifically in terms of staging of disease. Staging of disease may or may not be important, and this is an area of controversy. I mean, there are some surgeons in the business who are very expert and very experienced in saying nothing beats my hands. So in the operating room, I'll find these tumors with my hands, with my fingers. And I don't need the gastroenterologist to go putting tubes in all over the show to find these tumors. There are others that feel it's really important to know where the primary is, and taking the primary out makes an impact on outcome, which I think many of us are moving to believe now. And so although this is still a controversial area to some extent, looking for a primary is often useful. And in some patients who have unknown primary tumors, where we now know different tumors respond differently to various adjuvant therapies, it might be useful to go looking for the primary under that setting. You've all heard about the bottom of the slide, the cross-sectional and functional imaging studies, which I think I've got a few slides on, but what I'm going to focus on a little bit about the new endoscopy tools that we have. Optical endoscopy, which is upper endoscopy or colonoscopy, video capsule endoscopy, where you swallow a camera, deep enteroscopy, which are some new techniques. There's nowhere we cannot go anymore. And endosonography, which is an ultrasound that you can put on the end of an endoscope. So the role of endoscopy is really growing. Gastroenteropancreatic neuroendocrine tumors, or GEP-NETs, comprise the overwhelming majority of primaries. Eric did mention lung tumors, but I would like to mention, as a gastroenterologist, that the lungs are really just an offshoot of the upper GI tract. So that we claim those areas as well. And with modern techniques, endoscopy can now visualize the entire gastrointestinal tract and its appendages, the liver, the pancreas, the spleen. The small bowel we can get into with deep enteroscopy, which I'll show you, and the pancreas we can see very nicely with endosonography. We also have great new techniques endoscopically where we can biopsy things, we can tattoo areas for the surgeon to go find them, we can put in radio-sensitive clips, and eventually we might even be able to do local therapy, but that's still a ways away. So optical endoscopy, which comprises upper endoscopy and colonoscopy, and what used to be called push enteroscopy, which was a long upper endoscope, capsule, ultrasound, and the deep enteroscopy. The advantages of getting there with a scope is you can do a biopsy, you can measure amounts of acid secretion, you can localize exactly where a tumor is, you can allow the pathologist to give you a grade, which is going to impact on how we're going to treat patients, and you can even be therapeutic and take some tumors off. So we'll start at the top and we'll end at the bottom. Gastric carcinoids. The endoscopy will allow you to characterize gastric carcinoids. By measuring the pH and the gastrin at the same time, you'll be able to see if it's appropriate or inappropriate hypergastrinemia, or if it's a normogastrocnemic carcinoid. So there are three kinds of gastric carcinoids: type 1, type 2, type 3. Type 1 are seen as an appropriate hypergastronemic condition, low-risk carcinoids, low-risk tumors. I see many patients who are frightened by their previous physicians into being told they've got this terrible malignancy. It's actually a relatively benign condition. Type 2 carcinoids occur with acid secretion and Zollinger-Ellison syndrome. They're the less important of the two. The ZE is more of an issue, but you do have to address them. And type 3 carcinoids have normal gastrins that comes from a different cell type, and that's a malignant and aggressive neuroendocrine tumor, and that needs very different treatment. Endoscopic resection can be achieved with EMR, which we call endoscopic mucosal resection. It's a new technique in gastroenterology. You inject some saline or other substance into the mucosa underlying the tumor. You lift the tumor up off a base, and then you can cut it out completely without making holes. And that's especially important for early type 3s because we need to be aggressive with those patients. So this is David Metz's algorithm for managing gastric carcinoids. I hope others would agree. The first job is to get the pH and the gastrin. On the left, if the pH is high and the gastrin is high, it's a type 1 carcinoid. It's a low-risk disease. and you individualize therapy, but you tend not to be too aggressive. In the middle, the pH is low, the gastrin is high. That's a type 2 carcinoid from Zollinger-Ellison syndrome. You need to stage those patients and make sure about MEN1 and work with all of those diseases. Again, individualized therapy depending on the presentation. And on the right-hand side is if the pH in the gastrin is normal, that's a type 3 carcinoid. It's a high-risk lesion. It needs endoscopic ultrasound to see if it can be cured locally or if it needs surgery. On the left top, you see a patient with type 1 carcinoids, multiple large bulbous submucosal tumors. You look at that and you think, oh my God, that's terrible. In actual fact, that's a rather benign condition. I left that patient alone. She did fine for many, many, many years. The top right is a patient you can see atrophy or absence of folds in the stomach with a small little bump. That's also a type 1 carcinoid. I treated that patient the same way. The bottom right is also, these are all various presentations of pernicious anemia and atrophy patients. Here is a type 2 gastric carcinoid in a patient with Zollinger-Ellison syndrome and MEN1. The top you see the octreoscan with 2 hot spots. On the right you see the octreoscan with 1 hot spot. And the second hot spot on the bottom left are those 2 rather large type 2 carcinoids. They were big enough that I was starting to worry that they would become malignant. We took them off, as you can see, with a snare on the right-hand side. And this is a type 3 gastric carcinoid in the stomach, a large tumor. You can think of the center of this tumor as outgrowing its blood supply and dying, so it collapsed in on itself. That's why it's centrally umbilicated like that. And that's a bad sign. High turnover rate, high Ki-67, aggressive surgery required. Moving on to duodenal carcinoids. Multiple duodenal lesions are pathognomonic of MEN1 syndrome. If you have sporadic duodenal carcinoids, it's usually a single lesion. If it's multiple, you have to think of MEN with all its associated risks. Isolated lesions can be resected if amenable with endoscopic ultrasound if you show that there's no infiltration underneath. Also, duodenal carcinoid should be looked at in the operating room where the light shone through the wall so the surgeon can actually locate them because they're often very small and difficult to find. And whether you need to do an endoscopic ultrasound in all of these patients, I think is highly controversial. We tend not to do that, actually. Here's an example of a patient with many, many, many duodenal neuroendocrine tumors. And this was a patient that I saw from the old days at the NIH. Dr. Wank at the back might remember this picture, that big lesion in the top front there. We were so excited about. We thought, well, let's prove that we can take them off. And unfortunately, we made a big hole. So you have to be careful with these lesions because they are transmural. They start in the mucosa, submucosa, and they push up. So you don't want to put snares around all of these little things and cut them out because you're just going to hurt your patient. More importantly is to say this is an MEN patient, multiple tumors. We can't cure them. Control the disease. Don't hurt them. On the other hand, here's a tiny little duodenal tumor. The surgeon's hands are holding the duodenum with 2 fingers on the top and the bottom. The endoscope's inside, and it's shining a light through the wall, and that tiny little black thing there is a Zollinger-Ellison syndrome tumor. You need an expert to go find it. They need to know where to go, and they can take that tiny little thing out and control all your ulcer disease and cure you of that tumor. Endoscopic ultrasonography is able to distinguish neuroendocrine tumors, especially non-functional lesions. It allows for tissue diagnosis. It's especially important for insulinomas because they are always in the pancreas and the surgeon needs to know where to go look for them. They're helpful in assessing patients with MEN, and they're helpful to distinguish other hereditary syndrome. And here's an example of an endoscopic ultrasonography. In the top, you can see a little cystic lesion, which is unusual, and you can look at them with a circumferential or a linear probe and stick needles into them. My videos aren't showing over here, but on the left you see a round lucency, which is the tumor, and on the right you see that line going into it. That's putting a needle through the endoscope under vision into the tumor, sucking up a core, getting it stained by the pathologist, and you can make a diagnosis and aggressiveness determined at endoscopic ultrasound. Small bowel carcinoids are the last frontier. Video capsule endoscopy is non-invasive, but you don't get tissue, so I want to show you a little bit of deep enteroscopy. I think I'm running a little late on time, so I'll move up. Here's a capsule endoscopy showing a bulge. You need to know what you're looking at. This gastroenterologist sits in a dark room looking at 20,000 images from mouth to when it comes out the other end, and each little picture, looking at it as a video, you can see how hard it is to find these things. But the latest is this new endoscope. This is a double balloon endoscope. You can see it's got an overtube with 2 balloons, and the balloon can be slid along the length of the endoscope, so you can bring the 2 together and you can pleat them apart. Very clever, right? This is how it works, the double balloon method. You put the scope into the patient, you slide the overtube in. You then advance the scope as far as it'll go and blow up the balloon when it gets stuck. You then slide your overtube over to get to as far as the balloon is. You blow up your second balloon, you let down your first balloon, you carry on down as fast because now you've got it stuck, held by that balloon. You then blow your balloon up again, advance your overtube, pull everything out, straighten out the bowel, and you can watch your way down the entire bowel like this and get into the colon. Or you can do it from the other end. Put the scope in, get as far, blow up the balloon, put in the overtube, blow up the overtube, advance your scope, pleat it down, straighten everything out, advance your way up the colon, and then get into the small bowel, blow up your balloon, advance your overtube, blow it up, and carry on up that way and get all the way back up to the top again. So if you see what you can do now with these new modern double balloon endoscopes, on the left, you're going from the top until you get to the cecum, and on the right, you're going on the bottom until you get to the duodenum. You can see the entire gastrointestinal tract. You can tattoo things, you can snare things, you can take things off, you can tell the surgeon where to go. And here's an example of another video that isn't going to play of an ileal carcinoid that was found on double balloon endoscopy. The double balloon is not perfect, but it's very good, and it'll pick up lesions that the capsule misses. It does have some drawbacks. It takes a long time to do this. It's expensive, and it needs technical skills at an expert institution. The complications are actually rather mild and minor. Chronic acute pancreatitis has been described, and something we always worry about. Major complications, less than 1% of patients. There is a single balloon. I don't want to bore you with all the technology that doesn't go quite as far, but can also get deep. And then there's a spiral enteroscopy, which is another way to get into the deep bowel. But if you really want to see the entire GI tract, you have to use the double balloon. I'm going to now end off with colonic carcinoids, often discovered at routine screening. Many patients go for the routine colonoscopy because they're over 50, and I'm getting a call once a week by one of those patients. They found one. What am I going to do about these small lesions? Lower endoscopic ultrasound, again, will tell you if you can take these off, can look at for lymph nodes. And it's important that the gastroenterologist thinks of these, and we've got to make a gastroenterologist aware when they do screening to look for these. Here's an example of a terminal ileal carcinoid prolapsing in. Here's an example of something, if a gastroenterologist looks at that lesion on the left carefully, they can see it's yellow. It's got a central umbilication. It's behind pushing up as opposed to of the lining. And so it's a carcinoid, and they should know that, and they should lift it like the middle picture and snare it off and cure the patient at that stage. Anything under 2 centimeters. But what we often see is I took off a lesion, I thought it was a polyp, it turned out to be a carcinoid. What am I going to do? And then we're stuck doing what's showing for you over here on this picture. They come back within 2 weeks, and you've got to come back within 2 weeks because you can't find the lesion, it heals. And if you look at the bottom middle of the top picture there, there's a little red streak where the tumor was. You then can put a cap over it. You can suck that whole mucosa into the cap, put a snare around the cap, and chop it out like that and cure this patient. So there are patients who have small carcinoids in the rectum that unless they get recognized early, you can't render them cured necessarily because you can't go find the lesion at a later stage. Larger lesions obviously get treated very differently. And finally, the last role of the gastroenterologist that I do want to remind for everybody is that as doctors, unfortunately, there's side effects to much of what we do. We hurt patients. So people who've had pancreatic resections, either distal resections or Whipple's resections, can get pancreatic insufficiency, and they need enzymes to control steatorrhea. They can get dumping syndrome. Diabetes is obviously a consequence of our interventions that we have to treat. If you're taking somebody's spleen out, before you do that, you need to remember that it's important in controlling for immune symptoms. If you've had a terminal ileal resection, which many patients with carcinoid syndrome tumors have had, B12 deficiency becomes an issue to think about. Bile salt diarrhea, so cholestyramine is very helpful. Bacterial overgrowth gives diarrhea, and we need to think about all the non-neuroendocrine causes of GI symptoms. On the top right, octreotide, remember, gallstones. So my standard approach is I'm seeing Mr. Smith back and follow up with his metastatic neuroendocrine tumor. Gallbladder in, gallbladder out. I need to remember that. I put it at the top of my note every time to remind myself that octreotide and lanreotide can be associated with stasis. Steatorrhea is a side effect of too much octreotide, but you need it, so you need to counteract that with enzymes. And adhesive disease is something that some patients unfortunately suffer a lot from repetitive diseases. You've seen our multidisciplinary care talk. I'm not going to bore you about this, but it really is essential. You need lots of people in the room together to think about these patients, and a tumor board is the best way to do that. So thank you very much for your attention. It's a pleasure to see so many people here today. I'm happy to take any questions later on. A couple of quick points. Endoscopy is really useful in the diagnosis of management of GEP-NETs. We're now able to image and sample the entire GI tract. It's a cost-effective use of these interventions, however, that remains to be defined. So each patient's treatment needs to be individualized, and I think tumor boards are very, very important. So thanks for your attention.